So good afternoon, everyone. Welcome to our second class, HLED 100. Let's see who else in the meeting room. Okay, good. Um, Last day we started the first chapter, the first module in first aid and looking at your role as a first aider. Now, I would have put the first aid course outline, that course that requires, onto the LMS. I hope you guys would have gotten access to it as well as the PowerPoint, right? There will be additional items we would have to look at that's slightly different to the regular course outline and course content for a standard first aid CPR AED program. But we'll cross our bridge when we get there, and it'll actually be integrated into this particular program. So the last day we we went through quite a bit of areas, understanding what first aid is about, what is required, understanding how it impacts you, and then you making a decision to help, how you communicate with others is pretty important as well, right? Um, so we're gonna continue. We stopped at the starting of providing competent care, I believe. Correct me if I'm wrong. Um, at this point, we stopped last day. Is that correct? Anybody? Nobody knows? Nobody can remember?
I think we were at the ending of communicating calmly.
Right. So communicating calmly is right across here. Um, okay. So whatever, I probably just start back from communicating calmly. So thank you for that. Okay. Okay. So when you're interacting with a patient and the manner in which you converse or you communicate with this patient plays a major role and has a major impact on their response, their ability to become stabilized, um, the feeling of being reassured, and psychologically it impacts the scene. Okay. So typically, if we're on a scene and we're attending to a patient, or we're, let's say there's an accident on the highway or on the main road and you stop to assist, being able to render aid or to administer first aid starts with you being able to keep yourself calm. Okay, so being able to provide comfort and reassurance to the person you're helping, yes, that's important. But if you are unable to keep yourself calm, if you are panicking, running up and down and talking loud and screaming and all those things, it it aggravates the patient. It makes the patient believe that something is critically wrong, and they may deteriorate rather than being nice and calm and basically having their vital signs stabilized. This behavior may actually contribute to the patient deteriorating. So as much as possible, we encourage you to stay calm. It is easier said than done, especially if it is the first time you're attending that patient. Okay. So here's some quick guidelines to help establish a relationship with the patient or with a responsive patient. Okay. And typically in our country, as I said last day, it's a little bit easier because we are actually a friendly bunch of people. Okay. Contrary to what you might hear or see and those things and all the social media stuff. Typically, we are a friendly bunch of people, and in emergency scenarios, people pool together to help each other. Okay, so the first thing you want to do, if you can get the person's name, you want to use it. If not, don't beat up, don't fight up, don't get upset, don't get angry. Use a regular term that we are accustomed with. And if you're afraid of calling somebody auntie or uncle or moms or anything like that, sir and sir, ma'am, or as the case may be, whichever you're comfortable with. The easiest option would be if the patient is conscious to get the person's name and use the name. But it's not always the case that you're going to get it. Okay. Your first words to a person are very important because they set the tone of your interaction. And one of the most important things is to actually bring that level of calm to the patient. So many moons ago, right, when I was going to school, secondary school, there was this program. So back in those days, we just had initially it was just one TV station, and then eventually they went to two. So when we went from one station to two stations, that was like the heavens open up for us, right? To think about it, you guys are in an era where you have so much data, so much electronic items, um, so much media is available at your fingertips. And for us back in the days, all we had was one TV station and probably two or three radio stations. And then eventually it went to a second TV station. Okay. And I'm sure you probably would have seen a lot of those things on social media. But what I was getting to or alluding to, during that time, there was this particular series on TV, right? There was actually let me see, it was Kung Fu the something, right? And it was with this guy, he was a police officer and his father was this Kung Fu guy and all that sort of stuff. And it always started when he went to, when he got to wherever he is to help somebody who was in need of help. He'd always start off with, and it's gonna sound very corny, but I'm telling you this for a reason, right? He'd always start off with, I am Kane. I will help you. Okay. No, the reason I'm telling you that, and I'm sure it probably sounding very cheesy, but you want to have that level of influence and effect on your patient. So I'm not telling you, all right, so let me stop the share here for a little bit, right? So I am not gonna tell you like let's say, oh, I've seen so many people here too, right? So let's say like Glenn Roy. I'm not gonna tell you to go to a patient and say, I am Glenn Roy. I will help you. All right. Or Victoria. I am Victoria. Or I am Vicky. I will help you. I hope you're not upset that I say Vicky instead of Victoria, right? But yeah, so the idea why I'm telling you this is I want you to understand that that first level of interaction, the patient naturally forms an impression in their mind of the type of person you are. Just as I was saying last week, when you approach and the person looks at you and they may get an impression in their mind what type of person you might be and those things. As you say, the same concept, it goes across the board with all human beings. Okay, so your first interaction is important. Bring a level of calm to an emergency. Okay, if you ain't do anything else, bring a level of calm to the emergency. Tell the patient, I'm here to help you and I'm going to ensure you get help. Okay? But don't give false sense of security. You're looking at the patient, one limb severed, next one partially severed, major artery ruptured, and they literally bleeding out and like, no, don't worry, that just have flesh wound, you'll be all right. Don't do that. Tell the patient, don't focus on the severity of the injuries or severity of the condition. Listen to me. Let's work through this. Find unique ways to beat around and without saying, yes, you're going to die. Okay? You just had to be a little smart about it. Right, so we're going back up to the PowerPoint here now. Confirm when it's on your screen, please. So let's continue. You want to avoid negative statements that can add to the person's distress. So tell me something, right? How many of you have come across, and I'm sure you've come across accident scenes, right? Have come across an accident and looking at the way the vehicle's mangled, in your mind, immediately think, hmm, I'm sure people die in that. So we're going to stop the share again. I need to see the class. How many of you have had that impression? Just show your hands, raise your hands. Nobody? You're hearing me? Nobody look at that, ever
Yeah,
look at
still hearing.
I seen
Yeah.
one, two, three, right,
Okay.
four. Okay, good. So that's the interaction I want, right? So I'm sure, okay, good. So thank you. I'm sure we've all looked at accident scenes and we've seen and said, hmm, I'm sure people die in that. Case in point, the accident with the PTSC bus and the Honda Vezel where the 19-year-old young lady died. I mean, that was tragic. But when you look at the way the vehicle was destroyed, immediately you're like, I sure everybody in that vehicle died. Only to realize it's just one person. But again, the reason I'm telling you that is I don't want you in an emergency situation or a scene with a patient, you look and you make a statement, oh, he going to dead. No, don't do that. Or don't motion to your colleague, your partner, the sign that you're gonna get your head chopped off, running your finger across your neck. Don't be showing your partner that and your patient is right there watching, right? Or if somebody else asks you, he'll live, and don't shake your head and say no, right? You focus on the patient. So a lot of it, your subtle hints, your behavior, your hand signals, your gestures, those things can affect the patient. Okay? Avoid negative statements. Remember that. Avoid those negative statements. Okay? Don't ask unnecessary questions unless it aids treatment or satisfies the person's need to talk. So you're not gonna ask the patient, okay, so here now, you have any brothers or sisters? They're nice. What's their age? You seen anybody? That's not necessary. That's just you um you have issues. Okay. Sometimes patients will talk and some people in emergency situations they end up talking and talking. Leave them, let them talk. Eventually it helps to calm them down than to have everything bottled up inside. Give realistic answers to the questions, but try to be positive. Do not make a promise you cannot keep. So we spoke about that a couple minutes ago, right? Do not deny the obvious. But again, it's how you say it. Okay. Don't tell, gosh, your leg cut off, boy. You might be going to bleed and die. Or you're going to bleed to death, as some people say. Yeah, is it serious? Yeah, it is serious. But we're going to try our best to ensure we stabilize you here and get you to the hospital. Okay. Let's sidestep it a little bit. Discuss the person's condition calmly and honestly, but again, how you do it, um, really and truly, especially for life-threatening conditions, you have to be smart about how you're saying it. Okay. Whatever you are going to do to benefit the patient, for example, if there's a bleed and you need to apply pressure to the wound and then bandage, let the patient know, I'm gonna put some pressure on your hand to help stop the bleeding. And then I'm gonna bandage it. Or if there's a dislocated shoulder, look, I'm gonna put a sling and a sword to stabilize the limb. You're gonna get a little bit of pain while I put the sling in place. But when I'm done with the arm immobilized to the chest, the pain is going to be reduced. It's not going to go away, but it's gonna ease up a bit. Encourage the person to express their feelings. So let them talk. Let them talk. Then they're going to keep talking and talking and talking. That is okay. And the idea is to actually have that interaction. The simple thing for me as an EMT, the patient being able to talk tells me a couple of things. The airway is clear. The breathing, the heart beating. circulation, right? ABC is essentials for life. But also it tells me the brain is actually functioning and processing all these necessary thoughts and getting it to transcend into and be converted into speech. So there is some sort of appropriate brainwave function, brain activity taking place just from the person talking about stuff, right? But you also have to be able to discern what the person is speaking about. Discern if it's just utter total irrelevant things. Okay, so for example, right, again, and you're gonna get a lot of this. Me stopping the share back and going back and forth. So, Missy, Chrissy, how you going?
It's no.
You okay? Yes, yes. I need to raise my volume because I'm not hearing you. You okay?
Yeah.
All right. So, Chrissy, let's hear what I want you to select somebody, and I'm gonna ask that person a question. I'm given the opportunity to select somebody in class, and I will ask that person a question.
Um, According to the list.
Just pick one. Close your eye and pick one.
Okay. Okay. I slide through the list. This person I follow on is Sanjaya.
Ay, 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 Sanjaya. So suddenly, all the time, Chrissy voice nice and soft, you know. As soon as she realizes not she, the voice get loud, back to normal, right? So, Sanjaya, how are you?
Hi, sir. I'm all right.
Good. So here's something. If you are attending to a patient, right, and you ask the patient, "Sir, can you tell me your name, please?" And the patient tell you blue, what's gonna go through your mind immediately? Just that word blue, the color blue. Almost say the letter blue, you know, the color blue. Yeah. If the person says blue, what do you think? What will be going through your mind immediately?
Honestly, I would think something is really, really wrong with him, like really off, maybe like a stroke or something, because I know when they have strokes, you
Okay, oh,
didn't really know what's
skirk,
going on.
skirk, skirk, smash your brakes. You're punching nose. You're going too far. I just wanted to hold up, mash your brakes a little
Oh,
bit.
my bad.
Right. But yeah, you're right. You might think something is wrong, right? In this day and age where people giving their kids all kind of weird names, I mightn't think too much of it, but back then, yeah, something might be wrong. But let's take it one step further, right? So Sanjay, you select somebody now. You,
Amina.
Amina, where is Amina? Amina,
Good afternoon, sir. Good
good
afternoon, all.
afternoon. How you going?
I'm okay.
Right. So we coming back to this thing, right? The person name is Blue, and you say you ask the person, Blue what? Well, give me your full name, and the person say, Blue Marlin, right? So the person says Blue Marlin. Guys, just give me 1 sec. I need to mute for a minute here. Just give me 1 sec. All right, guys. So sorry about that. That's work. So and I might get one or two little interruptions in between. Yeah. So Amina, the person says the name is Blue Marlin. What gonna come to your mind?
A fish?
A fish. Exactly. Right. So hold up right there. Watch your bricks. Um, Shantor, you there? Shantor Tyson. Yeah, are you there?
Yes,
You there?
I'm here.
Good. So you hear somebody named Blue Marlin. What come into your
Can
mind?
you hear me?
Hmm?
You can hear me?
Loud and clear.
Okay.
So if you hear somebody named as Blue Marlin, what comes to your mind? What are you thinking? You thinking anything? Nothing?
Um,
I don't want the long, drawn
that's
out
the first
process.
name,
I
last
want,
name. It's
I, I
like
want what,
yeah.
I want what at the top of your head. You ask the person what's the name, and they say Blue Marlin. What immediately? What you thinking about?
It's a name?
Is a name?
Yeah.
All right. Okay. Cool. Thank
First
you.
and last name.
All right. Tanya, Miss Lancaster, are you there?
Yes, sir.
What you gonna think? And there's a reason I'm asking a lot of you guys to say.
I might think if that's a real name.
If that's a real name, exactly. But again, in this day and age where people asking, giving their kids all kind of weird names or what we perceive to be weird, um, we may not be so sure. So let's get back to the PowerPoint here. Where was I? Talking about the name, right? Um, right. So when we talk about encouraging person to express their feelings, sometimes by letting the person talk and hearing those things, we may be able to identify some sort of brain deficit, some sort of neurological deficit. But also it helps to calm the person down. Now, the reason why I told you guys about the Blue Marlin, that's actually a call I went on. Two brothers, they were having an argument about money. They owned both of them, they were doing very well for themselves. They own a couple fishing boats. They had a large seafood exporting business and all these things. And they started arguing about money. And one hit the next one a cricket bat to the back of his head. And when we got there, we attended to the patient. And I asked him, "So what's your name?" Blue. Blue? Yeah. Blue what? What's your last name? Marlin. So immediately I tell him that hey, I started to lean into the side of he has some sort of brain problem or neurological issues. And I asked him, I said, so Blue Marlin, where you live? The sea. Well, obviously something is wrong now. But again, it's only through questioning and having the patient talking and getting accustomed and comfortable with you. The ability to build a rapport with someone to instill that level of confidence and trust. Okay? Tears, laughter, these things, even being angry, all these things can be normal. Okay? One of the things you have to ensure the patient understands is that their response, it is normal and no need to feel embarrassed. The worst situation you might come across is somebody having an emergency in a school and the person loses bowel and bladder control. I saw a student, we went for a student actually who suffered a seizure in a school. And it was during a break time where there were so many hundreds of kids around. And I mean, some kids were just laughing and all this other stuff because the person would have messed themselves, would have lost bladder control, so they pee and mess themselves. And I mean, it's sad. So what we gonna do? We're gonna put them on the stretcher, we're gonna cover them with a sheet. And again, it's to protect their privacy and keep talking to them in the back of the ambulance, but the damage was done. So again, the first aider, your initial interaction does so much to instill a level of confidence and a level of comfort with you that the patient will develop. Okay? All this is part of being able to communicate calmly. But all of these things leads us into being able to provide what we consider competent care. And whether you're a first aider, whether you're a first responder or EMR or a EMT, a physician, whatever level of the field you are in, there is always something we refer to as the standard of care. And for your respective category, there would be a different standard of care. So in the case of a first aider, the level of care required of a first aid provider is referred to as the standard of care. Okay, and we go on to explain this now. So the first aid care or treatment that you are going to provide to a patient or to someone must meet, you must do certain things to meet the accepted standard of care. First thing is, whatever you're doing should be expected of someone with that level of training in a similar situation. So, for example, if you're at a restaurant or you're at a food establishment, and while having a meal, you observe somebody else choking or what you consider to be choking, and you spring into action. All right. You run fast, run in your washroom, change your clothes, put on your superhero outfit, uniform, coverall, whatever you want to call it, and you fly back out. And you offer to render aid. Okay? For a first aider, the treatment might possibly be encourage the person to cough. If they cannot cough or if the cough is too weak, you stand behind them, bend them over a bit, give 5 back blows between the shoulder blades. That doesn't work, you give 5 at the abdominal thrust, and you repeat the process until the object is expelled. Great. That is what is expected of you now. And the guidelines have changed a little bit over the last 2 years, right? From what it was before that, like 5 years ago, 8 years ago, and stuff. Nowhere in there did Nigel tell you about taking the index finger and sticking it into the person's throat to try to hook the whatever it is and pull it out. That it's not taught and it's not expected, it's not required. So when we're looking at standard of care, we are looking at different persons with the same level of qualifications would provide similar care if in a position with a patient of a similar complaint. So we have two persons, two first aiders, different parts of the country, and both of them encounter a patient with a laceration or a cut to the forearm. And both of them apply direct pressure, they bandage the wound and put a dressing and then bandage the wound. It's in line with what they were taught. But if one person put a bandage and the next person do stitches, somebody mix up somewhere. Somebody would not have provided the appropriate standard of care. Treat the person to the best of your ability. Think about, and this is where we tell you, think about if the patient was a family member of yours, what sort of care you would want. Now, last class, they had a field day with that. So, I had some family, I wish they were dead. And yeah, this being recorded, but yeah. So, let's look at a family member who you love and you cherish and you adore. Okay. When we continue providing competent care, remember medicine is constantly changing. And sometimes what we may have done decades ago is not practiced now. And some persons learning these things decades ago and not updating their knowledge might provide care that is no longer deemed competent or that is no longer accepted. And the easiest one, years ago, you would get smelling salts in first aid kits. At work, smelling salts is not used anymore in first aid because of the ammonia and the possibility of this toxic nature, this toxic substance getting into our lungs. So to be able to provide competent care, you must have up-to-date knowledge, current information. You do not want to use some of these outdated procedures, things like putting butter on a burn. You ever hear that? So we stop in the share again. Jamal, you ever hear about putting butter on a burn?
No, sir.
You never heard that? Okay,
Nope.
so you're in Antigua, right?
Yes, sir.
Good. So if you don't mind me asking, how old are you, Jamal?
I'm 25.
Okay, good. Nice. So can you enlighten us what was actually the remedy or the household remedy you would have heard about whilst growing up for somebody who would have gotten burnt? Let's say the ironing
Um,
and they got burnt, or they got burnt on the stove. Yeah, what you were familiar with?
we go outside and pick a piece of aloe vera plant and put it on it.
Aloe vera plant and put it on it, right? The aloe vera, it should be a
Yes.
right. Good. So that's a household remedy, right? So thank you. Let me see who else. Anjali or Anjali or Anjali, Miss Critchlow,
Angeles, sir.
Anjali. Very good. Yeah. Let me hear you. We're talking about the household remedies growing up, right?
Okay.
For a burn. What did you hear or what were you told to do or you've heard people do?
Um, I don't know if I'm remembering correctly, but I think Vaseline.
Thank you very much. Vaseline, petroleum jelly. And that was the number one thing in Trinidad you hear people talk about. For somebody who got burned, you put some petroleum jelly, some Vaseline on it. Um, yes, I am seeing you. Hold one sec, right? I'll call you O. Oh, hold one sec. Um, yeah, so definitely that was something we heard growing up, but we'll discuss why in a little bit why it's not recommended. Yes, Miss Lady. Oh, you can speak. You can go ahead. Where are you?
So you can call my Umaya. The name is Umadara.
Yes. Yes. Oh, go ahead.
I know you ain't call my name. Sorry, it's my hand. In case I forget.
Yeah.
You know, some people said that you can use toothpaste as
Right.
shame.
Good. So again, we're looking at some of the household remedies and toothpaste. I've heard that, right? So now the reason why I'm telling you, and thank you very much for that. Everybody who contributed, thank you very much, right? Now, the reason I'm telling you that, and I'll go back to the share now, right, is this outdated procedures. Putting butter on a burn is one. Using the petroleum jelly that insulates, that traps heat. The toothpaste contributes to the breakdown of the structure of the skin. Remember, toothpaste contains chemicals. Okay. Yes, we see this one here giving syrup of ipecac for poison, using a suction for a venomous snake. But that is the suction for a venomous snake bite. That snake bite kit has been proven to be effective in 1% of the cases it's been used. So much so that the university who that supported it withdrew their support. Putting an object. Okay, so let's this is a nice one. So I'm gonna stop the share again. Treatment for a seizure. Household treatment you would have heard for a seizure. Somebody tell me what you heard growing up, or what you heard people, even recently, what you heard
Turn
people.
them on this side.
Turn them on the side. Okay, good, cool. I'll take
Push
that.
a spoon in them out.
But who said that?
Afron.
Afron. That's the answer I was looking for. Put that spoon in him out. Right. Why?
So,
Yes.
um, well, this when you see them stretching out, like they could stretch out with the spasm,
Mm-hmm.
they say to squeeze the vein behind. Yeah.
Your data are really bad. Your reception are really bad. I'm barely hearing you. All I heard
Like when the
is
epileptic person stretching out
uh-huh.
is to squeeze the vein behind the ankle.
Okay, this is the first time I hearing that one.
Yeah.
Yeah.
I
Okay.
actually had an epileptic child and they told me that in the hospital.
You were serious?
Yep.
Okay.
She passed away. She had an epileptic attack.
Okay.
Yeah.
Well,
So they say like when they're stretching out,
mhm,
like there's real stretch out sometimes during a seizure,
mhm.
they say to squeeze the vein behind the ankle.
Okay, so this is the first time actually hearing that, right? I've heard a lot of other things, but it's the first time actually about that blood vessel behind the ankles to squeeze it. But anyway, what I'm getting at now, remember, this is where we might have a little bit of a difference between what you would hear in the clinic or in the doctor's office. We are looking at what we're doing in an emergency situation to render first aid, right? So let's go back to the share the PowerPoint here. Right. Putting an object between the teeth of a person experiencing a seizure, putting a spoon in the mouth, restraining them, all these things are things we don't practice anymore. Because again, whatever guidelines were developed here has been through research, analysis of data to come up with the treatment or the measures that provide the best benefit for the patient. But obviously, we look at balancing patient recovery and benefit and matching it against rescuer well-being. Whatever the rescuer does for the patient should not result in the rescuer suffering any negative effects. Okay. Previously, well, let's say between 5 to 10 years ago, we would have used pressure points to control bleeding. We don't do that anymore. Okay, and this is why it's so important to keep your knowledge base up to date. Being able to provide competent care, right? We should be familiar with some of these procedures. How to apply a tourniquet, how to use a hemostatic dress, excuse me, storing of a knocked out tooth, and a whole set of others. Leaving an open chest wound exposed without dressing or a seal, right? That one is still, even though it may not be taught at first aid, standard first aid, for the advanced first aid, the emergency medical responder, the EMTs, we do that. We put a seal. It's called an occlusive dressing, right? We put that occlusive dressing over an open chest wound, mainly because of the fact we do not want that pneumothorax to continue developing and restrict the expansion of one lung. Okay. So being able to manage patients with a suspected sugar emergency, a cardiac emergency, all these things, we need to be familiar with that. And it's important we keep our knowledge base current. Okay. So these are just some additional ones there. All right. So actually that's the end of the first PowerPoint here. So let me just close this off and I'll go straight into the next one here. All right, so let me just pull up the second one here. Right. And just get it share going again. So chapter one, understanding your role as a first aid provider. We're moving on now to understanding what some of the actions that should be undertaken before before helping. Okay. Now the PowerPoints I'm using in this program is actually from an institute in the USA called Emergency Care and Institute. Okay. And it's part of the program, but I'll not be using all the material. I'll be using some of it and augmenting it with additional information. Okay. ECSI provides a lot of emergency care training programs from first aid, advanced first aid, EM, emergency medical responders, bloodborne pathogens, a host of programs. Okay. All right. So let's get to, before we get to the patient, we do something called a scene size up. Okay. And a scene size up basically is us looking at the area where the patient is located and identifying what dangers there are, what dangers there could possibly be. Okay. And dangers would be anything that can cause harm to the patient and to us. Okay. So Let's go again. We're going to use a scenario here. An example. You're going to the mall, whichever country you are in. You're going to the mall and you encounter a motor vehicle accident. You know, being the first aider, the good Samaritan, the first aider who's wanting to help people, you decide that you want to provide aid, you want to render assistance. So you stop the vehicle, you come out of the vehicle. If you're traveling, you tell the taxi drive, I'm taking it here, but I want to try to help out this person. No problem. Taxi driver drop you off. But you remember from your first aid training, before you get to the patient who is involved in this accident, you need to do a scene survey. This is one vehicle ran off the highway or the freeway or wherever you're accustomed to and hit a lamp pole. And in so doing, when the vehicle collided with the lamp pole, the impact caused the lamp pole to fall on top of the vehicle. Okay? You've observed one patient in the driver's side of the vehicle. So what we're going to do now is I'm going to ask you, what are some of the dangers or some of the hazards that you think you may encounter as you approach and you attempt to render aid to this patient? What are some of the dangers you may encounter? So you guys could go ahead. Let me hear you. One vehicle ran off the road, hit a lamp pole fall on top of the vehicle.
Power lines.
Power lines, that's right. Excellent. Fall on power lines, which could give rise to what? Somebody else. Fall on power lines could cause what?
Electrical shocks.
Electrical shock, electrocution. Good. Nice. What else we have? Power
A
lines,
fire to break out.
a fire could break out. Excellent. Good. What else? Somebody else. Somebody else. We have power lines. We have a fire could happen. What else we looking at? Anybody? Come on, guys. Ladies, let me hear you.
Another accident could occur while on the scene.
Yes, another accident. So that's oncoming traffic. Definitely. Good. As people stop to look and observe, right? Or play fast. Right. What else? There's one particular one I'm looking for.
Broken glass.
Broken glass. Thank you very much, Ms. Budu Singh. So yes, everybody's correct. You guys with the power lines, the fire, thank you, excellent. Um, and then the broken glass, the oncoming traffic, these are all correct answers. Now, the reason I was waiting to actually get somebody to speak about the broken glass is twofold because it exposes you to sharp objects where you could get cut. The patient being exposed to the broken glass, let's say the shattered windscreen, the windows, whatever it is, will now could potentially have cuts and bruises on their face and body and the body, right? So the patient, this could give rise to the patient bleeding. You are now exposed to a potential bloodborne pathogen situation. So it's twofold. Broken glass could cut you, could expose you to bloodborne pathogens. But the patient could also be exposed to bloodborne pathogens from you. Because if you get cut, suddenly now your blood being exposed to the patient, that's a no-no. So these are some of the things you would look at when we're doing a scene survey. What is there? What is going on? How many patients do we have? Do I need additional help? Obviously, everybody needs additional help. Call for help. Call the ambulance, call the police, call the fire services. So unlike other parts of the world where you could dial one number and get access to all three, in Trinidad and Tobago, well, in Trinidad actually, in Trinidad you have to dial each number. If you call 811, if you call the ambulance, they can contact you. Sorry, not they can connect you, sorry, to the police or to the fire services. But typically we have three separate numbers for each service. In Tobago, I believe there's one number that you could call and select the appropriate extensions to connect you to the various departments. I hope I'm correct. I remember hearing that this was the way they were going to structure it. Okay, so we do a scene survey or a scene size up, as some personnel would say. And the idea is to identify what hazards are present. Sometimes, based on the hazards being present, you may it may be in your best interest to step back a bit and wait until additional resources arrive on scene to make the scene safe for you. Okay? We do not want you to suffer any negative consequences of attempting to render aid. So, when do we call the ambulance? Now, you would see on the screen here when to call 911. In Trinidad and Tobago, our number to access the ambulance service is actually 811. If you anybody knows what happens if you call 911? Wow, this gets squeaking, boy. Does anybody know what happens if you call 911 in Trinidad?
Then you just send the call back. They tell you to call 811.
Serious? So
Yes, I did
they
3 weeks ago.
they don't connect you directly to 811?
No, they said, ma'am, this is the police call.
Right. So
Ma'am, dial.
911 is automatically routed to our police command center, which is actually the 999 system, right? I know previously there was the option to connect you to the ambulance. I remember at one point in time there was a situation where I had to call the police to ask them to intervene in a situation with some personnel. But also there was somebody on the scene and I was no longer in the system, in the service. And the police told me, hold on, they were gonna connect me to the ambulance. So to hear this now is a bit strange that unless it is that particular dispatcher, because that connectability, interconnection, I know that was discussed a number of years ago in an attempt to ensure that those who needed the appropriate care could be directed or connected to the various departments. But okay, so but you were able to get through it 811 afterwards?
Directly.
Right. So sorry it happened like that, right? Now, according to the American College of Emergency Physicians, you want to call for help if if the answer is yes to any of these, right? Is the condition life-threatening? What we're looking at for life-threatening, anything that affects airway, breathing, circulation. So anything that affects the ability to breathe, anything that affects keeping the airway open, anything that affects the heart being able to pump blood. Could the condition get worse on the way to hospital? Will the patient suffer further injury if you move them? Further training and equipment required, such as that those of EMS. Distance and traffic, is that an issue? Okay. We want to look at calling for help for patients who encounter in these situations as well. Difficulty breathing, shortness of breath, any chest or upper abdominal pain or pressure lasting 2 minutes or more. A fast heartbeat at rest, all the things are abnormal situations. So it tells you something is wrong. Fainting or unresponsiveness, especially if it is a continuous occurrence or it happens more than once in a short space of time. Difficulty speaking or numbness or weakness in any part of the body. Sudden dizziness, all these things are conditions that can lead to critical situations. Confusion or changes in mental status, unusual behaviors, difficulty walking. Sudden blindness or vision changes. Obviously, definitely, that's an emergency situation. Something is wrong. Any form of bleeding that will not stop with direct pressure. Remember, all bleeding stops at some point in time. Every single bleed will stop at some point in time. We do not have an unlimited supply of blood in our bodies. So what we're trying to do is get the person to care before it is too late. Part of this program, we would discuss bleeding and how we manage bleeding. But if you have a patient who has a wound that is bleeding, and despite your best efforts, your direct pressure, your bandage, your use of the tourniquet, all those things, the bleeding is not stopping. Definitely, this person needs to be in hospital. Any situation with broken bones visible through the open wound or broken leg, drowning or suspected drowning, severe burns, changes in temperatures, extremely high or low body temperature, any allergic reaction. We have a host of them again. Unusual belly pain, poisoning or drug overdose, loss of consciousness, any sort of spinal cord, head or brain injury, a severe headache, any sudden or severe pain. These things are not normal. Severe or persistent vomiting or diarrhea, coughing or vomiting of blood, choking, psychological, emotional, or behavioral emergencies. All these are situations where it is recommended that you call for the ambulance, you call for help. Now, it does not mean that as a first aider you're unable to render aid. It may be that these patients may require stabilization and assistance of somebody who has a higher level of training than a first aider. But you could start to render aid. You could start to gather information so that when the EMT or the ambulance arrives, you have information, pertinent information. And the EMT or the nurse or the paramedic or the doctor, whoever it is you're handing over to, will be grateful for this information. So one of the things that happens that tends to happen is you hand over a patient and suddenly you hear the doctor or the nurse or the paramedic asking almost identical questions to what you are asking, despite you getting all the information, excuse me, despite you getting all the information, doing your handover and passing this data to the personnel, they ask back almost same questions. It does not mean that you're incompetent. It simply means that the person who is now responsible for the patient's well-being is asking the same questions in an effort to identify if the patient has improved, deteriorated, or is in the same condition. As always said, there's nothing about pulling rank or this I know and you don't know and those things. No, no, no. So being able to render aid even before we actually touch the patient, part of it means to be familiar with how to call for professional help, as crazy as it sounds. The years I spent in EMS, I probably worked about a few months, I think no more than 6 months in our comm center in dispatch. And when I tell you in emergency situations, when people panicking, a lot of them forget directions to the home. They forget the house number. They forget the color the house painted. So it's important to remember some of these things. So here's some guidelines. Now, when you call 811, and I will say 811 because we're in Trinidad and Tobago, but when you call 811, be sure to speak slowly and clearly. Don't panic and scream at the top of your lungs and use obscene language and those things, right? You need to be able to provide certain basic information. And we're looking at number one, your location. Okay. Anybody here ever look at Sesame Street while growing up? Or that was before you guys' time? Anybody ever looked at Sesame Street?
Yeah.
One, two,
Yes, yes, yes,
three.
a lot of Sesame Street.
Yeah, good, right. So I don't know if you can remember this particular little cartoon clip where there was an elephant asking a guy, I think it was for directions to the zoo. I hope you could remember that clip. And
Yep.
the gist of the skit was actually to show you the importance of getting directions, because when the elephant asked the guy and he said, you ask him, he said, I just paraphrase it. Excuse me, kind sir, or excuse me, sir, can you give me directions to the zoo? Sure. And as he said, go. The elephant said, go. Yeah, man. And he go and he take off. Run up and down everything, come back. Go where? And every time he says something, go east or go straight or whatever it is, the elephant would go and come back. Until eventually, I think he ended up giving all the directions and stuff. I really can't remember how the clip ended, but basically, it's the same. And the reason I'm telling you that is to go back to this year, right? Being able to give the person's location. So my parents, thankfully, and I'm happy that they're still alive. My mom panics very, very quickly. I mean, literally, she would literally freeze on spot. My dad is a calm guy. So, but he might forget a couple things. So what I have done, I printed out the directions to our home and I put it on their fridge, stuck it there. And my mom is a cardiac patient now. Recently she was diagnosed with that cardiac issue. And it's important to be able to have this information at hand. So I printed out the directions to our home, stuck it on the fridge, but also we have a list of all the medications that my mom taking. So it's there for in the event, and it's just, I'm not saying we're gonna call the ambulance, but what I'm saying is to be prepared. And I'm telling you, a lot of times when I went on calls for patients and they bring this bag, literally a bag. When you open the bag, it's like a pharmacy. It's a portable pharmacy with all these set of pills. And I was always like, so it would really be nice if I could just get a list of the current medications the patient taking and the dosage, the strength. And that's what I did. I basically pulled that and I have that. So in the event we ended up having, if we ever have to call the ambulance for my mom, we have all her entire condition. We have the directions at home, we have the conditions she suffer with, who her doctors are, what medication she's taking. These things are very important for when you get to the hospital because the doctor needs to know what you took for the day and what is your history, what conditions you suffer, because certain courses of treatment are not recommended for certain patients with pre-existing conditions. So you want to look at giving the dispatcher your location, the phone number you're calling from in the event you get cut off, they'll call you back. A brief account what happened, and this is relayed directly to the EMTs and the paramedics in the ambulance. How many patients require help? Any special conditions at the scene? And of course, the patient's description of the caller's description of the patient's condition and what is being done at this point in time. All right, guys. So, any questions? You guys there? Any questions? We have quite a bit more to include here, but I just want you to think about, let me just stop the share for a sec here. I want you to think about at home, think about your home, because one of the amazing things about first aid is you take this skill anywhere you go, and you can quickly implement a lot of these guidelines to help you at home. So I have the directions to our home on our fridge. I have the list of medications my mom taking, and even when we travel for vacation, I always leave one of my business phones with my dad, and I pre-program the number so it's like, okay, just hit number one, it connects to me. Hit two, it connects to my wife. Hit three, it connects to my daughter. All right, you hit four, it connects to the ambulance. Five to fire services. Now I have a sister is a nurse. I have a brother. He is a firefighter. So I would like to think we're in a little better position than some other people, but again, I prefer to be prepared. So at this point in time, I want to hear from you guys if you have any sort of preparations or any sort of guidelines in place for at home. These things make a major difference when the ambulance gets there or when you're giving information to the call taker or the ambulance service when you call, right? The dispatcher. Right? So let me hear you guys. Anybody has anything similar in place at home?
I do, sir.
You do? Excellent.
Yeah, on the
Excellent.
iPhone,
Yeah.
it has a medical ID stuff that you have to fill out.
Mm-hmm.
So when you hold down the power button 3 times, it carries you to that, and it gives you all the information of emergency contact, like my
Right.
mom, one so on to call, and
Okay.
so on.
Yeah, I see even with the I have a Samsung, right? And even with that, I have the medical information for myself. Emergency contacts, medical conditions, any allergic conditions as well. So yeah, so that's for you. Well, what about let me hear from somebody else now. What about at home? Your family members. It's all well and good to have our information, but what about our loved ones? Think about that. Anybody? Nobody? So you guys think this is something you could implement? It's not difficult, Just you'd be amazed to know, and I'm telling you from experience, you'd be amazed to know how many people mix up directions to the home. How many people they tell you, all right, come off the highway, you turn right. When you reach a big sand heap, you make a left. You drive for 3 miles and the sand heap, you ain't come across no sand heap. It's because the guys use it doing the construction. When you reach the big mango tree, make a left. They cut down the big mango tree. We want to use better landmarks than that. You get to the police station, you get to the fire station, you get to this particular street. Get simple, easy directions. And I hope you guys listen to me and then you guys take that information and implement it at your homes. Okay? Just some food for thought there. But let's get back to the PowerPoint. Right. So the dispatcher asks you, you give them a brief account what happened, how many people may need help, and any special conditions that is seen. So back to the accident, this scenario. How we controlling the oncoming traffic with this vehicle that ran into the light pole? Obviously, we may need law enforcement on scene to help direct traffic. So the person is trapped in the vehicle and there is the potential for fire and explosion, exposure to sharp objects. You may need fire service to extract or extricate the patient from the vehicle. These are the additional resources, and I want you to start thinking along those lines. Obviously, when you call for the ambulance or you call 811, you would give them a description of the person's condition and what is being done. Do not put yourself in harm to see exactly what is going on with the patient. Sometimes we do what we call staging. We stay at a safe location. Let them know, look, I'm at a safe location and this is what I am observing. They will never tell you go into the vehicle or get closer to the vehicle if you tell them you're staging at a safe location. Okay? Listen to what the dispatcher tells you to do. If you know you've done a first aid program, you let this dispatcher know, look, I'm a first aider, so I'm familiar with some of the things. If necessary, and you're able to write down the instructions, do not hang up until the dispatcher tells you can hang up. Okay? As much as possible, we always encourage everyone, stay with the patient until further help arrives. We see here EMS, but I'll tell you further help. Further help could be another first aider or somebody with a higher level of training, a first responder, an EMT on the ambulance, as the case may be. Okay? The idea here is we want to stay to reassure the patient. We want to stay to comfort them. We want to stay to see if whatever treatment we've administered, if it continues to be effective, or if we need to make any sort of changes. All right, so um, I want to come back to the legal aspects of first aid in a little bit. All right, I just want to take a short break here and try to find some water somewhere. So, guys, I'll just stop the share here for a sec. Let's take a 5 minute break. It's 22 minutes past 6. So let's take a 5 minute break and we'll start back. I'm just gonna see if I can find some water in this facility down here. All right, so I'll just pause the recording. We'll start back in 5 minutes. Okay? Right, good. So as I was saying, we're looking at the legal aspects of first aid now, right? And we have some similarities when compared to the US and some differences. Now, on your screen here, you'll see this statement. While you may not be legally required to help another person, most people believe helping others is the right thing to do. So it's typically when you look at an something called a moral obligation, and as we get into the occupational health and safety side of it, we will look at that concept of um, moral requirements, moral guidelines, moral obligations. So it's more providing voluntary care and enshrined in the concept of doing the right thing to help your fellow man, or what we call for the greater good. Okay? But that is voluntary care. Some of us may have what we call a legal duty to act. For example, it might be part of your job description or employment requirements. So, for example, if you're at work and your organization has an occupational health and safety management system, and within that system is an emergency response plan. And within the emergency response plan, you would have first aiders or safety wardens who are both trained in first aid and basic fire safety and prevention. And you are a first aider here, you are a safety warden in this structure on a particular floor or department or location of the building. In the event of an emergency that directly impacts your team, your department, you may be required to respond. And at that point, it is your duty to respond. If you have accepted the post, you've accepted the training, all those nice things, right? So if you're one of those few organizations, if you're part of one of those few organizations who actually pay an additional amount onto your salary for functioning as a warden, you've accepted this, you are legally required to respond. If, however, you upon being selected for this training, you indicate that I am unable to function. I don't feel confident enough to function, or I'm afraid of blood, or I get woozy when I'm trying to help someone, or I'm afraid of fires, I'm terrified of fires. No problem. Nothing is wrong with that. The organization will very simply select another warden, and that is okay. All right. So when do we provide care? We can provide care on a voluntary basis, or if we have a legal duty to respond. If there's a pre-existing relationship, such as a parent and child, teachers and students in school, Of course, with the teacher and the student in Trinidad and Tobago, the Ministry of Education has some preset guidelines that you would need to comply with as well. Okay. Even with when we talk about drivers and passengers, these school maxis or school bus, these minivans, these school bus, the yellow vans in Trinidad and Tobago, a requirement to have to renew your license, to initially obtain the license, and then to renew the license to operate a school maxi. You must have defensive driving training and you must have valid first aid training. You have to present that to the licensing office to get your approval to operate. So typically, all right, here we go again. Lay responders must be extremely cautious when revealing information that was learned while caring for someone. It's very simply this idea of keeping patient information confidential. Okay? You must keep patient information confidential. Only share what must be shared to the parties directly responsible for providing patient care. Other than that, it is any other person who has the patient's expressed permission or any other person who has a valid court order. There were many times when I was working EHS in San Fernando. Our base was actually base one at Rushwood Street in San Fernando. We had a number of instances where police officers came trying to get information about a particular call or team went on during their investigation. And of course, our shift supervisor, our team lead, and these people would always advise them, please get authorization from the court for us to release the documentation to you. You could question the team, no problem. They will give you information what they would have gotten, all right? But we cannot release documentation without a court order. Everybody hear me? You guys here? Hello?
Yes, sir.
Yes, sir.
I see somebody had a message here. Um, check that afterwards. Right. So the law recognizes that we all have a right to privacy. So our information should not be broadcasted everywhere. That's why we try to maintain, and we always try to maintain a level of confidentiality. Patient confidentiality is very important. It is critical. Okay? So you're going to reveal only what is needed to be revealed to only parties who are directly involved in patient care or persons with the patient's expressed authorization. And usually we look at that in writing, or someone with a valid court order. Right. Moving on, we have something called the Good Samaritan Law. And typically, Good Samaritan laws provide, as we see here, reasonable protection against lawsuits and encourage people to help others during an emergency. So the concept of the Good Samaritan Law basically looked at some of these items here. You're providing care with good intentions or in good faith. You want to help this person. You are providing care without the expectation of compensation. Okay, so you're providing care, and at the end of it, it's not expected that, well, we don't expect you to tell the patient, yeah, that'll cost you 100, or that'll cost you 500, or that'll cost you 1,000. No, you're providing care on a voluntary basis. You are providing care or you are acting within the scope of your training, whatever training you have, you're acting within that scope. So Nigel will teach you, all right, for choking, this is what you do, for a bleed, this is what you do, and these things, right? Nigel will not tell you, so for a bleed, you're gonna stitch the wound, or for somebody who's choking, um, you're gonna do something else. Okay. You are not acting in a grossly negligent manner as well. So the concept of the Good Samaritan law is that you should not suffer any negative consequences such as litigation because you wanted to you tried to provide voluntary care, you tried to do a greater good. Okay. However, within recent times in other parts of the world, we've had people challenging the Good Samaritan law. Okay. So let me ask you guys here now. Do you guys think we have a Good Samaritan law here in Trinidad? Anybody? Do you guys think we have a Good Samaritan law here in Trinidad and Tobago? Class, get quiet, boy. It sounds very quiet. Today, you guys
Yes,
quiet.
sir. A lot of people will help at accidents and take persons to the hospital.
Right. So that's the actions. While looking at legislation itself, the laws of the
No,
Republic of Trinidad and Tobago.
we don't have big legislation with regards to that.
Okay.
It's
Anybody else?
voluntary.
Anybody else? Thank you. Anybody?
I don't think so.
Okay. Let me hear you guys. Ciara, what's your opinion? Ciara, Iran, Priyanka, Vidasha.
Never really think about it, so
All right. Fair enough. I'll take that. I'll accept that. We never thought about it then. No problems. All right. So, hmm, let me just get something here. Anybody want to Google it or go online and check it? All right. So let me just give you a little guideline what was taught to us. We do not have a Good Samaritan law per se. We don't have a law entitled the Good Samaritan law or something along those lines, right? We believe in the concept of the Good Samaritan and procedures, the guidelines, those concepts, right? What we have is the Medical Board Act, right? And let me just see if I could pull it here and share it with you guys. Yeah, find time to update. Yeah, find time to update. Let me just try somewhere else. I'm just trying to pull this here, right? Just okay, good. So it's coming up here. Um, I just wanna scroll on to the applicable section of it. Get in there. Right. So we have the Medical Board Act of Trinidad and Tobago, right? And it specifies who could be engaged in the art of healing, of diagnosing, of treating, performing interventions and techniques and all these nice things, right? And typically to be able to provide care, you should be registered with the medical board. But here in our country, only physicians are authorized to be registered with the medical board. So the act actually goes on to say, you could perform all these skills if you are acting under the direction or supervision of a medical practitioner, which is somebody who's registered with the medical board. If you are functioning under the authority of this person who's licensed with the medical board. If what's the next one? Yeah. Right. Yeah. So those two main ones. The act also goes on to say nothing in this act, and this is very important here, right? Nothing in this act shall prevent any person from giving the necessary medical or surgical aid in cases of urgent need without higher gain or hope of reward. And that is similar to the act here, the Good Samaritan, the concept of the Good Samaritan, being able to provide care on a voluntary basis without the hope of higher gain or reward. Okay, so and that's actually under section 23(3) of the Medical Board Act. So you guys can feel free to look it up and just have it there, because it lists all the guidelines of who was registered and what they can do. If you're not registered, what you're not allowed to do. And of course, then we go to the voluntary care. Okay, so feel free to look at that. Right. Any questions so far? No questions? Everybody okay? Everybody following everything? I'm not hearing you guys.
Okay. So we understand.
Mm-hmm.
Yes, sir.
Mm-hmm. All right. So if you understand, let's see. Let's see if you guys understand.
Wait, so it's a question.
Yes, sir. Let me hear you.
Concerning the act you just mentioned, right? So,
Yeah.
like, is it possible that you could still be sued if then
Yep.
you are not a physician and
You
you
could still
decide to
anybody could be sued. Yes, you can. That is the right that any person has. You could sue anybody. Just as we see in other countries where we have a lot of people taking persons to court. Yeah, it could happen. I'm not going to tell you no. However, the act, once you are functioning in line with what is listed stated there in the act, you're pretty much safe. I've never come across in the 25 years I've been in the system, and even with personnel who've been in the system under the Ministry of Health, we've never come across persons who've been sued for providing voluntary care. Make no mistake, there will be an investigation if somebody decides to take action against you. There will always be an investigation in an attempt to identify the facts that is normal. Ultimately, once you provide care in line with what is outlined there, I'm sorry, if you provide care in line with what is listed there, you should be pretty much okay. I am not a lawyer, I'm not a magistrate, I'm not a judge, so I cannot make pronouncements on whether you will be exonerated or not. Because I myself, outside of my regular function, there have been many times I've stopped and provided care, and I've always stayed within the boundaries of what I've been trained to do. Okay. All right. So any other questions? So I appreciate that question. Thank you very much for that. Anybody else? No questions again? All right. So let's continue. Let me just share here. Right. Negligence. So we've seen a couple of times on the news where somebody passed away, somebody died in hospital, and suddenly there's these accusations of negligence. Just again, flung all about the place, which happens, right? But we can't just say somebody has been negligent or confirm somebody has been negligent without, again, due process and investigation to identify the facts surrounding the situation. And when we look at negligent actions, and of course, we want to try to stay within the realms of first aid for now. When we look at negligent actions, we're speaking about giving substandard care. So if we go back to the standard of care, what different persons with the same level of training would do if placed in similar situations. One person probably decide to apply pressure, put a dressing, and then they bandage the wound. The other person decide to do stitches. Somebody is doing something wrong. Withholding care when you have a legal duty to act. So you know you're a warden, there's a co-worker who suddenly started to feel weak and dizzy and needs your assistance, and you refuse to provide care, you refuse to render aid, you could be held liable. Causing injury or harm by your actions in your attempt to help the person, or you would have deliberately, this person required aid, and you deliberately, while treating or stabilizing, you deliberately did things to cause further harm, exceeding the level of your training. So Nigel is an EMT. Nigel know to insert a oral and a nasal airway. Nigel know to suction and all these things. But with a patient, Nigel decided to cut the throat, stick a pen barrel inside there for them to breathe. I mean, this is extreme, but it's just an example. It's a really nice example. I've way exceeded the level of training. Abandoning the person. We're talking about starting care and stopping or leaving without ensuring that somebody else with either the same or higher level of care or training is there to provide assistance for the patient. If you make the decision to start, you need to see it through, or at least have somebody with the same or higher level of training take over the patient care from you. And as always, there will be an investigation. There will be statements taken, facts collected, and a decision made. Excuse me. Okay. When we're looking at consent, always obtain consent, always get permission before providing first aid. Because part of it involves us touching and assessing and these things, right? So it's important that we obtain permission to provide care, to render aid, as we say. Okay. So let's see what we have here. So if the person is, constant Wi-Fi. So if the person is mentally competent, of legal age, and gives permission verbally or with the nod of a head, basically we provide care. This is what we call express consent. If the person refuses help but the injury or illness is serious, try to convince the person that they need assistance based on what your observations are, and let them know the ramifications of not accepting their help. Of course, every area where you want to call for help, call 811 or call 911 as the case may be. Okay. Try to have somebody there as a witness to confirm your events or your description of what happened. If there's no one there, call it into somebody. And I always tell all participants in my programs, every single call to 811 and to the police is usually recorded on a call logger. And it's stored for a period of time. Call for help. Pass the information to the dispatcher so you're sure the information is being recorded somewhere. If you're at work, call your supervisor, pass the information to your supervisor. Okay, you tell this way, look, Jeff bleeding and Jeff don't want me to provide care, or doesn't want me to help him. Any person, adult or child, is unresponsive with a life-threatening condition, we utilize the concept of implied consent. We make an assumption that this person, if he or she was thinking clearly and logically, and they would accept your help. If there's a parent or a legal guardian present, or they could be quickly contacted, obtain permission from them. But here's one part of it though we have to add. Do not delay treatment for a minor, and typically anybody who is under the age of 18 in Trinidad and Tobago, we class them as a minor, right? Even the teenagers, once you're under the age of 18, with the ambulance service, they need to get authorization from a parent or a guardian. Okay? If they cannot be contacted, you do not delay life-saving intervention. You're outside of the ambulance, you're a lay person out on the road, you're a first aider. You try to get the relatives or the parents, but you're not getting through to them. Do not delay life-saving interventions. And again, I'll tell you, call 811, call the ambulance, have the call recorded somewhere. This is your saving grace. Okay, so that's your backup plan to get that level of protection for you. An adult who is mentally incompetent, unable to make rational decisions, try to get just get, yes, Omar, go ahead.
So,
Yes.
understand what you're saying? Like, if you have to attend to all the parents, try to get on to somebody or call the police
Mm-hmm. Okay,
so that credit on it at the time.
I hear you and I hear you sporadically. You're breaking up in bits, so I don't know. Anybody want to assist you? Anybody here now? Where you could assist me? Anybody? You guys who there?
I believe she said something along the lines of if you don't have money on your phone, what would you do in that situation with regards to attending to a child in an
If you don't have
emergency
money,
situation?
right? If you don't have money on your phone, the call is free. You don't need to pay for the call. Call. So when you call the emergency services, here are the benefits. One, you have a trained dispatcher to provide information and guidance for you. How does that benefit you? You are now taking instructions from a higher trained, certified person. So you're taking instructions from them. Two, the call is being recorded. What you found, what you're doing, and then based on the information relayed, the dispatcher tells you what to do. So you're not making decisions on your own, or you're following instructions. These are the things to take liability off your shoulders. Even if you have no credits on your phone, the call to the emergency services is free, right? Up to, I believe, 2008, we still had the 7-digit numbers, the 6244343 and 6534343, depending on which part of the country you were located. That changed when they switched over to the 3-digit access 811. You no longer had to pay for the call. Okay, so yeah, if you don't have credits, that's not a problem. And of course, I would encourage anybody, even I do it. If I'm on a scene and I want to help, I still make that call to the emergency services to have that level of protection for myself. Just have that level of protection. And you know what? Half of the time when I call, the dispatcher is somebody I worked with previously. Right? And like me too, you say, well, seeing here trying to help out and okay, no problems. And of course, I know the call's been recorded, so it provides a level of protection for me. Okay. All right. So I hope that helps you a bit. PPE, personal protective equipment. Typically in healthcare, you would hear healthcare providers referring to it as BSI, body substance isolation. HSE, everybody else, we say PPE, personal protective equipment. The idea of using PPE is to provide a level of protection so we do not get contaminated with any infectious material. But it's not just to protect us. We also look at providing a level of protection for the patient. Okay. Some of the typical some of the typical PPE used by healthcare professionals include disposable medical exam gloves, such as the latex-free gloves, the nitrile gloves, eye protection, such as goggles, face shield, barrier devices for CPR, face mask, CPR microshield. First responders, EMTs, paramedics, they may use something called a BVM, a bag valve mask. Um, Common reference in the hospital is the Ambu bag, but Ambu is a brand, right? The correct name is a BVM, a bag valve mask. Face coverings to prevent disease transmission. And that is the whole concept of utilizing personal protective equipment in first aid and in healthcare to prevent the transmission of potentially infectious material. We're going to be dealing with body fluids, and it's not just blood. People drool, some people vomit. Okay. So we may be dealing with a lot of body fluid. So that's why it's important for us to identify and utilize the necessary PPE while we're managing our patients. Okay. And we have some examples here. The disposable exam gloves, the barrier devices, the face shield, the face mask. Right. You have a face shield on this image here. You have a face mask. I don't think I need to go through this and basically how to put on a mask properly. We've all learned that with COVID, right? We've all learned that. We've all learned how to properly wash our hands. Okay. In terms of cleaning body fluids, always make sure you're protected. Wipe up the body fluid paper towel, and of course, then use a sanitizing solution. You can use bleach. Some people use bleach, some people use other solutions, but the easiest one that's available is actually bleach, the chlorine bleach that kills bacteria. Okay, kills all those things. And of course, you spray it on the area, let it air dry. And this is generally accepted concentration to mix that is sufficient enough to kill any bacteria, any germs, any contaminants, whilst at the same time not having any adverse effects on you. Okay. We do not dispose of any biohazard in the bins. What I would tell it should go in a garbage bag. If your first aid kit does not have a biohazard bag, you could get a regular garbage bag, put this stuff in there, seal it. You could visit your health center or your accident and emergency department and just throw it in the biohazard bin. That's it. That's all. Um, Twice a week, I believe the transport vehicle passes and picks up all the biohazard material to take it to the incinerator where it's incinerated. Of course, when you finish, you make sure you wash your hands. Soap and water. And again, I am not going to go through the process to wash hands. We've all learned these things during this entire pandemic that happened a couple of years ago. Okay. Oh, so that's it for that one. Questions? So that's slide number 2. Right. Probably go through a couple others. Yes, let me hear you guys. Questions? Shana, you have any questions?
No, sir, I understand what you said.
Okay. Is everybody here? 1, 2, 3, 4, 5, 6, 7, 8, 12, 13, 14, 15, 16, 18, 19, 20. Okay, cool. I know 25 people would have registered, enrolled, but I'm only seeing 21. I'll figure out what's going on here. Hold on. Guys, do me a favor now, please. Open up the chat and I want you to type in your name, first and last name. Can you guys do that for me?
Yes, so not a problem.
Great. Go ahead. Good. So I'll get that a little bit later. I just want to make sure so that when I'm entering everybody's attendance on the form that they send me. Okay. All right, cool. So let me just pull another PowerPoint here. There was somebody in class who would have served in the US military, and you are I think you're a medic from there. I forget who was the person. I don't know if you're in class today. You guys remember somebody was saying that last week? Yeah. Okay.
Yes, sir, that was me.
Oh, that was you. Okay. So what level you got to? Paramedic?
No, actually, I wasn't a medic, but that was just part of the first aid training
Oh,
that
that
we
was
had
part
to
of
go
the
through.
training. Okay, okay.
Yeah.
All right. All right. Okay, good. I understand better now. Okay. Let me get another PowerPoint up. We'll do part of it and then we'll wrap up in a few minutes, right? I want to try to complete the first aid before we get into the occupational health and safety side of it. So moving on, we're looking at checking an injured or ill person. Okay. And it's important to remember all these programs. If you go back to the very first slide, we spoke about the concept of to manage a patient, we use the concept of find it, fix it. It can typically be described as an assessment-based care model. To manage your patient, you need to assess, figure out what's wrong, and then you start to provide care. Okay, and we always start by trying to identify. Now we're looking at here um, after the scene has been made safe. Okay, after the scene has been made safe, we add the patient. We always assess what we consider to be what we term their level of consciousness. Can we do that by calling to the person, tapping on the shoulders, we shout. If we know the name, we use the name, right? And we don't tap them on the head, we don't cuff them, we don't kick them, we don't assault them or anything like that, right? We very simply shake the shoulders, tap them on the shoulders, call out to them, try to get a response. If they don't respond, then we shout for help or make the call for help. Let when you call 811, you let the dispatcher know you have an unresponsive or an unconscious person. Yeah. And they will guide you on what to do. But everything starts with trying to get or determine what is the patient's level of responsiveness. Okay. Of course, we check for breathing. Typically, for somebody who is responsive, the normal, healthy person, breathing is something we don't think about. It's done automatically, and we're looking for rise and fall of the chest. With the unconscious person, you should have called the ambulance. And abnormal breathing, we're talking about noisy breathing. This may not always be the case. We're talking about very little rise and fall of the chest. In some cases, breathing end up being absent where there's no rise and fall of the chest. These are times we want to get help. We call for help because whatever is going on with the patient may be way beyond what you are trained to do. Okay. For somebody who is breathing normally and they're unconscious, we turn them on the side. Putting them side lying like in the picture here allows the tongue to fall to the side of the mouth, and that way it allows the airway to remain open so the person could actually breathe and they have a passageway, a clear passageway for air to get into and out of the lungs. Make sure you would have called the ambulance. Call that ambulance. Get help. Okay? We want to check for any severe bleeding. We've checked level of responsiveness. We've turned them on the side. We've checked for breathing. We're looking for circulation. I'm looking for severe bleeding, sorry. If there's any severe bleeding found, figure out which part of the body is coming from and stabilize it. Okay? Scan the body for any medical ID tags, because sometimes they may have a medical tag telling you they may be allergic to certain things or they may suffer with certain conditions. And it's very easy while you're quickly assessing the person to look for these things. Okay? But that's for the unresponsive person, the person where you tap and you shout and you call out to them and you don't get any response. Okay? The majority of patients will be responsive. And of course, we call out to them. Now we see on your screen, you would be seeing, ask the person, are you okay? And if they respond, you introduce yourself and all these things, right? Again, here in Trinidad and Tobago is a little bit different because of the friendly nature of our population. Okay. And typically as we approach, hey uncle, how you going? Everything all right? And the person says yes. I cool man, I good. Everything I don't know why they call you. Just by making these statements, or even that one word response, yes, it tells me the person's airway is clear, they're breathing, whether it might be normal, abnormal, but the fact is the person is still breathing, so there's a level of gas exchange taking place. They're responding, they hear me and they respond. You know, the heart must be beating. So there's circulation taking place. Whether it is adequate or not, left to be seen, but circulation is taking place. So those are the essentials for life. And you want to check for any severe bleeding. Now you ain't get to the patient yet, you know. You ain't get to the patient yet. Okay? As you approach, obviously identify yourself. I am Uncle. My name is Nigel. I'm a first aider. Uh, we got some information that you're not feeling well or you may have had a injury. Can I assist you? Whatever information you got, you use that when you're freezing so that you identify the specific condition and you ask, can I assist you? This is the conscious patient. The patient could respond to you. And of course, it's up to the patient to say yes or no. If they say yes, then great, you have access. If they say no, you try to convince them. But why you don't want me to help you? I'm not charging you any money. I'm not carrying you anywhere against your will. I'm not going to injure you. I just want to check and make sure you're okay. And if they still say no, then obviously no means no. But you try to convince them to seek medical attention. Right. When we're checking the responsive person, you want to ask some questions to try to figure out if they know where they are, right? I mean, usually we look at place, time, and those things like you know where you are now, you have any idea what day today is, you have any idea what the time is. Those simple questions they could identify, and it tells you their thought process and logical thinking, the ability to process information and give you a reply. You want to quickly check for difficulty breathing, but you ask them, are you having any difficulty breathing? And then you check for any major bleed. Blood spurting, the clothing soaked in blood, all these things. Or blood is pooled around them. What we're looking at here is the essentials for life. A clear airway, person breathing, bringing in oxygen, removing carbon dioxide. The heart is beating, circulating blood. I want to ensure there's enough blood to be pumped throughout the body. This is where the assessing for any severe bleed is important. So Let me ask a question here. You're doing your assessment of a patient. I keep forgetting this chair is noisy. You're doing your assessment of a patient, and you realize your your patient has a severe bleed. You realize your patient has a severe bleed to the left leg, right? Or just below the knee. Yes, I will be posting all the slides, right? May not necessarily be tonight, might be tomorrow. So if I get a chance tonight, then I'll post it tonight. So back to the scenario. You have a patient with a major bleed to the leg. You're approaching the patient and you see it. You call out to the patient, you get your response and all those things, right? And you're taught to do an assessment, ABC as the case may be. The patient is talking to you, right? Giving you a little history of what happened and those things. Are you going to allow the patient to continue? And when the patient is done talking, you're going to see about the leg with the major bleed, or you're going to tell the patient, look, I need to very quickly check this bleed. This is a lot of blood here. I want to try to stop this bleeding. What are you going to do? Anybody?
So, yeah, if you tell them they might inquire you to touch it, so you try to do what you have to do in order to stop the bleeding.
Right. So if they don't want you to touch it, how are you going to stop the bleed?
And they try to reassure them that if you don't stop the bleeding, it could, get worse. So something lead to that.
Okay. Anybody else? Come on, guys. Let me get your opinion. There's a major bleed to the patient's left leg below the knee. And you've approached the patient, you're the first aider, and you are in the process of assessing the patient, and you observe that major bleed. Are you going to continue your assessment and getting information from the patient and stuff, or are you going to go directly to where that major bleed is and attempt to stop it?
You attempt to stop the bleed while you can still talk to the patient.
Okay. Anybody else?
Make sure it has nothing harmful around and then try to stop the bleed.
Okay, so you make sure the area is safe and then try to stop the bleed. Okay. Anybody else? Once you have permission to provide care for the patient, you look for these life-threatening conditions. Life-threatening conditions would be anything that affects the airway, such as the patient is choking, or if there's an obstruction, any other obstruction. Breathing difficulties, sometimes the inability to breathe or the inability to breathe properly. Circulation, major blood loss. Once there's a major bleed or any bleed, any severe bleed for that matter, we're not talking about the little scrapes and bruises. We're talking about profuse bleeding. We focus on stabilizing that bleed as soon as possible. So if you guys could remember, I said initially, all bleeding stops at some point in time. We want to ensure we stop the bleed before it is too late for the patient. Okay? I picked up a patient in California, right down the road from where I live, over there, 10 minutes from my home. She and her boyfriend had an argument. And during the argument, it got violent. and he stabbed her with a knife just under her right breast. When we got there, police wasn't there, but the relatives, they brought her into the ambulance for us, and she was bleeding profusely. All I could have done, I couldn't do anything else. I couldn't even get a set of vitals because all I could have done is take a trauma bandage and put it over the wound itself, just under the breast there, and apply direct pressure whilst my partner proceeded to the ambulance, to the hospital with her. When we got there to Cuba A&E, the doctor, we got her into trauma, started managing her. So they set up a drip line, put her on oxygen, and then he cut the area there. And well, obviously, well, he put in a chest tube and they did a couple other things. She stayed on our stretcher and they asked us if we were willing to transfer to San Fernando. We got permission from our comm center. This bleed was so critical. When we got to San Fernando, actually, when we got to where just before, well, at the time, South Park wasn't built. South Park was only built recently, but by that time, there was UTT San Fernando was called San Fernando Technical Institute. When we got there and the road was really bad, something happened and that clamp came loose. And it took us probably about 2 to 3 minutes from across there to San Fernando General. And I was looking at this woman changing color from initially she was bright red. She got pale and eventually she got ash gray. And that tells me she was losing too much blood. They tried in resus, but couldn't save her. She died right in resus. And that's why it's so important for major bleeds. Remember, I'll go back to the statement. All bleeding stops at some point in time. We want to try within the boundaries of what we're trained to do to stop that bleed. Sometimes, whatever you're trained to do, you may not be able to stabilize the patient sufficiently. Unfortunately, that's just how it is. I was not trained to put in a clamp, to put in a chest tube and all these things. So it had to be the doctor doing it and a nurse in the ambulance with us to go into the hospital. But even that wasn't enough. These are just examples, right? Yeah, sure. We actually wrapping up here and it's 20 past 7. I just have a few minutes again, so that's okay. Sure. All right. Let me see how far I have again with this PowerPoint. So I'm on 8. Yeah, just about 4 or 5 slides again. All right, so let me just get back to that. Right. Quick survey for any severe bleeding, stabilize it. In terms of difficulty breathing and stuff, we'll discuss those things in another session. Always remember initially you scan for the life-threatening conditions and attempt to stabilize it. Take a note of what you've done so when the other professionals get there, you can relay that information. Make a call for help. If you're around, if there are people around, you can ask someone to call for help. If you're at work, ask a colleague to call the ambulance or whatever response mechanisms you have in place. Quickly scan for any medical tags, medical ID bracelets and chains and those things, right? When you call, and I'll tell you, call the ambulance or call the emergency services as soon as possible. So sometimes you might miss certain guidelines or measures to provide care because you're not practicing every day. You're not actively looking for a patient every day. But the emergency services, they deal with hundreds of patients every single day. So the dispatcher would be able to give you pertinent information very quickly. Make that call for help. Okay? And you're using mnemonic sample once the patient is conscious when you're questioning to get the guidelines. Okay? So what I want you guys to do for me, just take a note of this app, right? I'm gonna screenshot it and put it on the WhatsApp group. Let me just get it here. Oh, I have it or delete it. We get it right here. Right. So it is from National Safety Council USA, right? I would have just put it there. It is the NSC First Aid Guide. I think it's about 60 megabytes. You could download it and have it on your phone. What this app does, it gives you pertinent information to provide care for a host of conditions the patient has, whether it's medical or trauma. I will encourage you guys, please download it and have it, because ideally you're doing this program as part of your curriculum this semester, or the courses, the list of courses this semester. So I don't expect you to be looking for patients every single day. As a matter of fact, you live your entire life without having to manage a patient in an emergency situation. But at least this app here gives you guidelines on what to do if you have a patient at home, at work, on the road, wherever it is. Okay, guys? Yeah, so you're using mnemonic sample where each letter represents something, pertinent information. S, signs and symptoms, what you see or what the patient tells you is going on with them. Is the patient allergic to anything? A, are you on any medication? Okay. P, pertinent past medical history. Do you suffer with any medical conditions? We're looking at any medical condition, asthma, diabetes, high blood pressure, any strokes, any surgeries, anything like that. L, when last they had something to eat or drink. And of course, E, what the person was doing leading up to this situation. What you do when you got hurt. Okay. So sample provides critical information very quickly. But honestly, I know in these cases and in these classes, a lot of times it's difficult to remember sample. So that's why we all say we're going to remember it because it's simple as an acronym. Doesn't always work that way. So that's why I tell you guys, download the app, have it on your phone. Nothing is wrong with getting it and referencing it and taking a minute or two to get to the relevant condition and see what the guidelines are. Now, I've been in EMS for 25 years. I've been in HSE for about 22, 23 years. I've been teaching as well for around 15 to 20 years. These things are second nature to me, but that's not the case with a lot of people. So if I can give you a tool that can make it easier for you, then that's what I'm going to do. So the NSC First Aid Guide, please download it, have it. You can share it with your colleagues in the other class. You guys, let me see what else we have here. I'll leave dots for only dealing with injuries, and I'll just skip those pictures. Yeah, the header too. I'll do that next day. I think I'm gonna close off the PowerPoint here and stop the recording. I'll stop the recording now, and our next class we'll continue with the rest of the PowerPoint, the last two aspects of it, because I want to speak to you about something else now.